Now, this is the role of exercise. Good strength training. Right. Thank you very much for that lovely introduction. And I'd like to thank Dr. GVK for once again inviting me here and Lily for sponsoring me. Now, all material presented today is supplied by Eli Lilly. I have no academic conflicts of interest, but I am sponsored by Lilly for this talk. So why are we talking about weight management and early intensification? Because I think these are the two things that give you a legacy effect. Like Dr. No, he's gone. Okay. Like Dr. Chandrasekhar just mentioned, even if you lose 15% and regain 5%, you still have a net 10% benefit. And there is, like with glycemic legacy, there is also a weight-related legacy. So managing, and to a large extent, obesity and insulin resistance is the root cause of a lot of the metabolic dysfunction that we see. So early management and early weight management as a integral part, I should say, of diabetes management is, I think, a shift in our mindset in how we manage diabetes away from just managing the glucose. UKPDS, I mean, we've been seeing this data for nearly 25 years now. And we know that early intensive management, we know that UKPDS was a population of newly diagnosed diabetics. For them, conventional control was 7%. Intensive management also averaged just around 6.5 to 7%. Over a period of time, that actually deteriorated. But that early intensive control for the first 2 to 4 years after the diagnosis of diabetes, in the subsequent follow-up and the UKPDS follow-on studies, what we know is that this has led to a significant reduction in mostly microvascular outcomes, but by the time you had the legacy data, you also had an improvement in your macrovascular outcomes. So as you can see, over a period of time, even people, and UKPDS people were started on a single drug, but eventually, okay, no, let's go one back. Where is my, okay, no LED screen, no laser, I think it's okay. Let's try this. Yeah. Most people required multiple agents within the first 3 years, and certainly by 9 years, most people were on, almost everybody, 4 out of 5 were on polypharmacy. And you can see that if you look at the UKPDS data, we know that at the time of diagnosis of diabetes, most patients had lost, we can't talk about beta cell mass, what we can talk about is beta cell function, had lost about 40 to 60% of their beta cell function. But over a period of time, over the next 8 to 10 years follow on, what we know is that there was an average loss of beta cell function of about 3.5 to 4%. The initial aggressive, if you will, lowering of the A1C on with the sulfonylureas wasn't really sustained long term, and this was thought to be initially due to the deterioration in beta cell function, because that's the primary site of action for sulfonylureas. We also know that not just diabetes, but people with overweight and obesity are also at a higher risk of developing complications. And again, this goes back to the statement I made that the root cause of a lot of this pathology is obesity and insulin resistance. So what the enhanced data collected over 30 years, 40 years from 1988 to 2018 shows us is that people with diabetes with a higher BMI are about a quarter, 25%, nearly more likely to experience microvascular complications and more than 50% likely to have cardiovascular disease, heart failure, heart attacks, and strokes. So the moment you add weight as an equation to your diabetes, the risk of your complications goes up. And the EPIC data, again, with BMI in people with diabetes, you can see again, I have a good. Okay, a 20% higher risk for every 5 kilo per meter square in terms of microvascular complications, nearly 40% for kidney disease and 12% for neuropathy. So add to the BMI, and every 5-point increase in BMI increases 20%, 40% and 12% in terms of your microkidney and neuropathy complications. So if beta cell function, and we've said, is crucial to sustaining blood glucose control over a long period of time, is there anything we can do to stop this deterioration in beta cell function? So what you can see, the direct trial, and you know that the direct trial actually was a primary care-led trial which aimed to reverse or put diabetes into remission, and there was a anticipated or aimed for 15 kilo weight loss. What they looked at was 15 kilo weight loss at 12 months. Nobody achieved it in the control group, but only 24% achieved it in the intervention group. Please remember, this is pre-GLP, GIP combinations or individuals. But at the same time, remission was about 46% in the people who lost the weight mostly, and sustained remission at 12 months in relation to weight loss. If you lost less than 5%, it's about 4%. If you lost about 5 to 10%, about a third, you needed at least 10 to 15% to put about 57% of people, and more than 15% of your starting weight loss, 15 kilo weight loss to get an 86% chance of remission. So clearly, the more you lose, the better your chance of remission. And in those days, even though they aimed for about 15 kilos, they achieved about 11 point something kilos. So achieving even that was only possible in a quarter of the intervention group and in none of the non-intervention in the control group. Weight loss is difficult. Maintaining weight loss is even more difficult. Now, what happens is that with weight loss, you actually see, if you look at the slides for the pancreas morphology, the pancreas morphology and insulin secretory capacity actually improves over a period of 24 months. So you can see down here, the beta cell capacity and the pancreatic morphology at baseline 5, 12, 24 months improves in people, and there is improvement in insulin secretion in people who actually were in the intervention group. So if you have a non-diabetic comparator, you're nearly reaching that kind of a level of a non-diabetic comparator with a significant weight loss over a period of 24 months with a significant weight loss. So your pancreatic morphology and insulin secretory capacity improves with weight loss. Now, excess weight control we divide it into three, right? Metabolic complications, your type 2 diabetes, hypertension, hyperlipidemia, your coronary artery disease, and your fatty liver disease, MASH, MASLD. Then you have mechanical complications, your osteoarthritis, your obstructive sleep apnea, things like that. And then you have mental health complications, which again, please Lily, put them on the slides because they are an integral part of treating diabetes. Don't ignore it, right? And your micro and macrovascular complications are all, as I've shown you, affected by your initial BMI. So why are we looking at controlling glucose downstream and controlling macro and microvascular complications downstream when we ought to be doing insulin resistance and weight management upstream to then be able to mitigate both the glycemic and extraglycemic effects of obesity and insulin resistance down the years? We need to change our mindset we have to a large extent changed our mindset from being glucocentric with diabetes, but I don't think we've gone far enough in thinking in terms of BMI as an integral early part of managing diabetes. Weight management is an integral part of diabetes management early on, because we know that 3 to 5% weight loss starts improving your blood glucose and your blood pressure. Starts. But please don't think that 3 to 5% is enough. A 5 to 10% gives you a metabolic improvement, but to see a significant improvement, whether for sleep apnea or fatty liver disease, you need at least 15% or more. Think of it as a continuum, as a spectrum. There is no point at which somebody falls off the cliff. The more you lose, the greater the benefit in terms of your metabolic and mechanical and mental health complications. So when you're choosing glucose lowering therapies, the ADA and now the Indian guidelines have also firmly moved in the direction of saying, please look at medications that have a beneficial effect on weight loss along with your cardio-renal things that we've now become used to over the last 8 or so years. That was a humongous shift in the ADA guidelines about 8 years ago, where they went from recommending metformin and SUs as a first line to then giving us the algorithm that looks as cardio and renal protection. But now they've included the weight, and especially with a high dual glucose and weight benefits like your dual GLP, GIP and GLP receptor agonists. So then this comes to, so that's part of the weight and early glycemic legacy. But let's look at again early intensification of treatment in type 2 diabetes and how does it benefit us. We know that in India especially, the step to introducing a second line therapy can be as long as 3 to 4.5 years. So, and this isn't peculiar to India. Unfortunately, the world over, when you look at treatment intensification, and especially in people not achieving glycemic goals, we know that this leads to a lifetime of complications and legacy. Everywhere in the world, the average duration is 5 to 7, 8 years. And most patients spend an average of 9 years with poor glycemic control before we even start talking about insulin or anything else. So why does this matter? Because we know that the micro and macrovascular complications continue to be a major concern in people with diabetes, a major concern for personal well-being, personal resources, finances, health, everyday well-being, but also at a systemic and at a societal level. The spend on healthcare from these complications is huge. And more than that, people die of heart disease. Whatever else their complications, they die of cardiovascular mortality, and cardiovascular mortality continues to be the driving cause of death in diabetes. And what have we done to alter this over a period of decades? So the DISCOVER study looked at the prevalence and 3-year incidence of vascular complications, even in patients with a shorter duration of diabetes if it is poorly controlled. And the Swedish National Diabetes Registry and these Scandinavian registries are one of the best sources for longitudinal observational data. In people with diabetes of 6 years or longer, the major adverse events are cardiovascular compared to matched non-diabetic controls. So cardiovascular disease is still the leading cause of death. We've known this since UK PDS that 50% of patients already have complications at the time of diagnosis of type 2 diabetes. And I've said 40 to 60% average, 50% loss of beta cell function at the time of diagnosis. This 2/3 is highly optimistic for India. We know from various data that that's more like nearly 80%, 75 to 80% of our patients do not achieve an A1C target, not under 6.5, but under 7. And the majority require polypharmacy to achieve these goals. And we know that polypharmacy is delayed in India by 5 to 6 years. So this UKPDS, this is what I was talking about. The trial ended. Glycemia was more or less equivalent after the trial ended. Most people, whether in the intensive control arm or the conventional arm, achieved an equivalent effect in terms of their glycemia in the follow-up study. And yet people who were in the initial intensive arm and had a reduction in their glycemia eventually had a 16% reduction in microvascular, 33% reduction in MI, and 27% reduction in all-cause mortality 15 years. 5 to 15 years after the end of the study. So early intensive therapy, this is what is called the dysglycemic legacy or the glycemic gap, which drives these complications later on. So in people with an A1C less than 7 within 1 year versus not achieving less than 7, this pink is the difference of 26%, 67 at 5.5 years. They have an increased risk of strokes, heart attacks, heart failure, and composite CV events of 62%. So if you don't get this 1 year under 7 kind of data, you are exposing your patients to a 50 to 66% risk of cardiovascular and cerebrovascular mortality within 5 years after diagnosis. Early intensive control prevents micro and macrovascular complications, because what is micro today will eventually affect your macros as well at some point. And this inability to achieve early intensive control will show up within 5 years, as I've just shown you, in terms of adverse outcomes for your patients. And where we talk about glycemic legacy, this is dysglycemic legacy, what we can achieve and the gap between what we haven't achieved. So if you take away nothing from this, please be aggressive. My consultant, when I was doing my training, used to say, hit it hard and hit it early. Hit it early, hit it hard. That's the formula. In addition to glycemic control, weight is an independent risk factor for cardiovascular adverse events in diabetes. A weight loss goal of 5% is a start, but please don't compromise. Push if you can, and with the newer drugs, we should be able to achieve a 10 to 15% because this is where the real metabolic change starts for your patients. And the guidelines have seen the light and have moved away over the last decade and a half from being glucocentric to being much more inclusive in terms of initially macro and microvascular complications, and now addressing weight as a comorbidity that should be hit early, that should be hit hard. So early prevention includes good glycemic and weight targets early on for your patients with diabetes to stabilize or hopefully to improve their long-term dysglycemic effects. Thank you very much. I'm going to hand back to the chair. I am apologizing in advance because this was a late-ish invitation and I had a prior commitment, so I have to run fairly shortly.
Okay, we are